Hey everyone, I hope you're well. Today we have Charlotte presenting on occupational therapy. So Charlotte, whenever you're ready, you may begin.
All right. Hey guys, good evening. So I'm going to be talking about occupational therapy today. So just a little bit about me. So my background is I graduated from California State University, Long Beach in 2018 with my Bachelor of Arts in Human Development. And I also got a certificate in gerontology. And for the past 3 years since I graduated, I've been working as both a physical therapy aide and an occupational therapy aide in an outpatient orthopedic clinic. And beyond that, I have experience in occupational therapy in various settings, including outpatient pediatrics, inpatient rehab, and outpatient orthopedics. As of right now, I'm in the process of applying for occupational therapy school for the upcoming cycle. And just like a few fun things about me, I volunteer with guide dog puppies, which is one of them seen down below. I enjoy going to coffee shops, taking care of my house plants, and some, pre-COVID hobbies include concerts and traveling. So I broke down this presentation into 4 different sections. So first, what is OT? What education do you need to become an OT? The settings they work in, and the overall benefits. So right off the bat, um, occupational therapy has been around since I believe it's the 1960s, but it often gets misconstrued for being physical therapy. I work as an occupational therapy aide now, and every day patients would be like, "Thank you so much for all your help in physical therapy." And it's like, it's not the same, or people think that occupational therapy is about getting a job. And it's just kind of misinterpreted. So, occupational therapy it focuses on helping people from any age, from babies to older adults, help them get back to their activities of daily living and what brings them meaning. So that can include, being able to drive to work, being able to, eat, sleep without any pain, different, just what you would do on a normal basis. And from the AOTA, which is the National Occupational Therapy Association, they outline it as living life to the fullest by helping them promote health or prevent or live better with injury, illness, or disability. So, in a way, occupational therapists get to be tour guides. So, they help patients to be able to realize, okay, here's your diagnosis. This is what we're going to do to like target the what needs work and give them the clues to get there. So, like I said before, physical therapy and occupational therapy, although they're very similar, they also have their prominent differences. So, physical therapy focuses on movement, mobility, and function. So, if someone tears like their rotator cuff, they're treating specifically the shoulder by helping them strengthen the muscles and bones around it. Whereas occupational therapy treats the whole person in terms of their wellness, rehabbing whatever they're coming in for, and habilitation. So helping them their home life, what they're doing on a daily basis, getting them back to work, and their meaningful occupation. So whatever brings them meaning. So that differs from one person to another, but it can include their hobbies, jobs possibly, or activities which bring them joy. So that could be um, golfing or knitting or whatever they do on a daily basis. They kind of use like as a stress reliever, which provides them with some joy. In terms of the education needed to become an OT, there's a pretty straight route to get there. So first and foremost, you have to have a high school diploma. And then after you graduate from high school with your high school diploma, you have to get a bachelor's degree. But unlike other health tracks for occupational therapy, it doesn't necessarily matter what you major in, but some common majors that people choose are kinesiology, sociology, bio, and in my case, human development. But I have friends who've completed occupational therapy school and had, different majors like history or art or things like that. But everything in its own way can be tied back to occupational therapy. And then in terms of a graduate degree, as of right now, you only need a master's degree to practice as an occupational therapist. You just have to pass the national certification exam. Um, Unlike physical therapy, where you have to have a doctorate to practice now, they voted, I believe it was last year, and they said that you can still, yeah, practice with a master's. Or if you were more of like a seasoned therapist, like you got your bachelor's degree in occupational therapy many years ago, you're still allowed to be what they call grandfathered in. So you don't need to have your master's or doctorate to practice. But it definitely makes you more competitive if you have your master's or doctorate, just compared to like if you're applying for like transferring from one job to the other. And a huge thing, especially nowadays, is it must be an accredited program. And the accreditation is just that the program has met these different qualifications that are found in quality education, such as like new courses or advancements that have been made in different treatment plans. And then once you pass your program, you graduate, um, you have to pass the MBCOT, which is the National Certification Exam. Once you pass this national certification exam, then you can move to the next step. So picking out what setting you want to work in, or if you like are pretty open, then you have a wide variety of options to choose from. If you want to work in a specialty field, such as like a hand therapy, which is where I work currently, you have to work for roughly 5,000 hours or 5 years of work experience and pass another board exam so you can earn that board certification. But you can be, when you're coming out of occupational therapy school, you're a generalist. So technically you could go from working in pediatrics to a skilled nursing facility to like an outpatient orthopedic clinic with minimal, I mean, you still have to know the information, but it's not like you're doing a complete career change. I outlined a couple of the board certifications. This is not all of them. There's at least 30 plus for the board certifications and specialties, but I thought I'd just highlight a couple of them. So gerontology is where my background is in. It's working with older adults. You can work in mental health, pediatrics, physical rehab, hand therapy is like where I work now, lymphedema, working with patients who have a lot of swelling. And does anyone know what hippotherapy is? I can't see the chat, but I'll give you like a minute or two. I guess I just kind of unveiled it. It's working with horses. So the patients that might be a candidate for this are children who are on the autism spectrum, have cerebral palsy, and I don't have a huge understanding of it, but from this picture and the description of it, the child is working on balancing, spatial awareness, and it just like occupational therapy can be found in like a vast variety of different settings. But for hippotherapy, so working with horses and having therapy while on the horse, this is one of those certifications that you have to sit for the board exam and pass it in order to be licensed to practice it. And then some of these other specialties, driving and community mobility, feeding, eating, and swallowing, that's really common in pediatric settings. And also school systems is really common in pediatric settings. So there's a lot of avenues that you can take if you want to become a therapist, especially an occupational therapist. And it's not unheard of to switch from one setting to the other. So I listed a lot of settings, but there's obviously more than this list includes. I put some asterisks, but besides the ones that I have experience in. So inpatient rehab would be in a hospital. So patients, their treatment plan would differ from someone who's like an outpatient orthopedics. Like their inpatient rehab, their treatment plan might just be getting from their bed to the rehab gym. So using their ADL skills, so being able to sit up on that side of the bed, ambulate to the therapy room, be able to work on different like fine motor skills, improving their range of motion, all sorts of things. But each setting, what they have in common is they're treating the patient as a whole, and each patient has their unique treatment plan based on their needs. So if someone has lacking like grip strength or range of motion, then the therapist will focus on those areas in order to move forward. So help them slowly increase these skills through short-term and long-term goals, and it helps them to really curate the plan, especially for them. And then like outpatient pediatrics, so all the outpatient ones are patients that'll go for their appointment and then come home, so they won't be staying overnight or anything like that. And traveling occupational therapy is a really cool field as well. So it's also called home health. That's when if patients have just had surgery or they're unable to drive themselves to their appointments, the therapist will come to their house and complete the therapy with them. So that could be, helping them get around the house, whatever they're lacking, and if they need help with toileting or being able to maneuver a wheelchair around their house, making sure everything is safe to get around. And then lastly, outpatient hand therapy, which is the setting that I currently work in. So just for reference, this is the clinic that I used to work in. I'm in the same company. We just moved across. In the shopping center. We moved across the street. So it was really small. This was shared between the physical therapy department and the occupational therapy department. So in the left corner, there's like a white U-shaped table. We just had like a small little nook and cranny of the office. And then this is our new clinic. So we have a lot more space. With COVID, we had to do socially distancing, so keeping the tables 6 feet apart. In the corner, there's like the shelves, and then there's like a drop in a metal container. That's what we call a hydroculator. We keep our heat pads in there to warm up patients' hands, wrists, or elbows before they're seen by the therapist. And then I have a better picture on the next slide, but there is another metal container in the corner. It's a splint pan, so we make custom splints. And then to the left of that is a white container. It's called a paraffin bath. I don't know if anyone's heard of it before, but it's a container that is kept heated, and we put hot wax in it. So if patients come in with really stiff fingers, we can dunk their hand in the wax and let it harden, and it usually helps to loosen their fingers up, which is beneficial for their treatment plan. That's considered one of our modalities. So I work in outpatient orthopedics. So I work with an occupational therapist who has her doctorate, and she's not currently a CHT, a certified hand therapist, but she is going to sit for the exam soon, so she can still practice as a therapist. But if you want to get that certification, it'll help boost your resume and your credentials as well. Some of the common injuries we see are carpal tunnel releases. So that's right by your wrist, and it is usually seen in people who overuse their hands. So if you're repetitively typing, or if you're like, we see a lot of hairdressers, housekeepers, things that you're constantly overusing your wrist. And then common injuries we also see are finger and wrist fractures. So we have some funky looking pictures on here. The one in the middle with all those loops, it looks like it's pulling their hand back. That's what we call a dynamic splint. So the white part, that is the custom thermoplastic material. So if you look at the bottom right, that's the splint pan. When you drop the material into the bath, since it has hot water, it makes the material more pliable. And so they can form it to their hand or whatever specific ordered splint the doctor has provided. And those little, they look like little hammocks. They are to make it a little bit more comfortable for your fingers to force them into extension. So they're fingers might droop a little bit. So by having those little hammocks, it helps to keep them extended. And just in general, what we see on a normal everyday, we help patients to regain their range of motion. So if you fracture your finger or your wrist, you're not going to be able to bend it very much. So we help them, give them exercises to work on grip strength, pinch strength, everything that will help them to return to their meaningful occupations. So whatever brings them joy, that can include their job, hobbies, whatever they're trying to get back to. And also fine motor skills, reduce inflammation is huge too. Unlike if you have like sprain your ankle or something like that with hands, it usually takes a lot longer for swelling to go down. So that can be anywhere from, well, it depends on your age. If you're younger, it's usually a lot quicker. But with older adults, it can take to about a year after surgery. And while occupational therapy is mostly concerning just physical injuries, we also treat the whole person. That includes their mental state as well. So helping them to instill confidence in themselves and their abilities. Sometimes patients can come in and be very dissatisfied with how fast they're progressing if it's really slow progress. So we try to help them along the way so that their journey towards eventually being discharged and done with therapy, they increase their confidence along the way. So here are some of the equipment tools that we use on a daily basis. So I didn't include all of them, but some of the more like funky looking ones I included. So this first one, those 4 rods that kind of look like churros, those are called flex bars. We use those to help increase range of motion. And then the one to the right of it, those are called digiflexes. So there's 4 little notches. So your 4 fingers, your index, middle, ring finger, and pinky would sit on those. And we would work on finger flexion. And then the one to the right of that is called a juxtaciser, or it's sometimes called a wire maze. So there's a little ring on one side, and the goal is to get the ring from one side to the other just by moving from the wrist. And then far right is a power web. There's a lot of things you can do with a power web. We do it a lot for gentle stretching, but can also work on grip strength if you put your fingers through the side of it, or if you can make a fist and punch. So whatever the patient's needs are will differ from like what they're going to do with each piece of equipment. And then I didn't put pictures of these, but I think they're pretty self-explanatory. The gel balls, it's just like a squeeze ball that's smaller. We have ones that are shaped like Easter eggs, and they differ in resistance. So they would squeeze the gel ball, and that would help. Like if they could do it with like individual fingers, their thumb and index finger, things like that. And pegs, like wooden pegs or big colored pegs, we'd have them place them on a board and take them out individually. So they're working on their fine motor skills, being able to grip the pegs in order to take them out. And then the sponges are just really small rectangular sponges that differ in resistance as well. And we use that for grip strength as well. Okay, and then at the bottom, on their first appointment, we take a lot of measurements to know their baseline. So if they injure, say for example, their right wrist, we would take all the measurements for the right wrist and for the left wrist to know what we're trying to get back to. So the unaffected side would usually have higher grip strength or range of motion than the affected side. So the dynamometer is the one where it looks like there's a guy squeezing a handle, like it's towards the middle, and we test grip strength with the dynamometer. Then in the bottom right, there's no technical name for it. I don't believe we just use it for pinch strength. So the person on the right's hand, where they have their index finger on top and their thumb on bottom, is called a lateral pinch. And we'll also test a tripod pinch, which is your index finger and middle finger glued together and your thumb on the bottom. And then we have two types of goniometers. So the one on the top to the left of the dynamometer is used for wrist range of motion, and the one on the bottom that's metal is used for finger range of motion. There are also larger ones similar to the goniometer on the top, used for shoulder range of motion, but it's basically the same idea as the wrist goniometer. And then the Semmes-Weinstein monofilament test will be on the right side, just above the pinch strength, and that is used to test sensation. So it has a really thin, almost like a thread, little piece that comes out of looks like a pencil almost, and it feels like fishing line, like a very gentle touch. And it'll start out really faint, like really thin thread, and the normal sensation is 2.83. And say, for example, if someone has nerve damage, they might not be able to feel on different parts of their affected body part. So we'll increase in, like if they don't feel it the first time, we'll move to the next level. And this helps us to know what we need to work on. If they have a lot of like lack of sensation, then we might consult their doctor, see what would be the next steps. And then lastly, the benefits of OT. So I just included 4 categories. There are obviously many, many more areas that can be added to this list. But first and foremost, return to ADLs. So activities of daily living. So what you would do on a normal basis. So feeding, being able to like hold a spoon, cut with a knife, and then dressing, being able to independently dress, put buttons on, um, being able to button your pants, things like that. Ambulating, being able to get around the house, walk from one place to another with minimal difficulty. Working, so working could be if you're still employed or working around the house, like chores, yard work, things like that. Toileting kind of goes without saying, but being able to sit down on the toilet and get up with no trouble. Um, all of these categories are areas that we can have adaptive equipment for. So that would be something like if there's a traveling occupational therapist that comes to someone's house, they'd be able to help them specifically with these areas. So that could include like a raised toilet seat or adaptive equipment so it's easier to grasp a spoon. Might be like ambulating, so that could be like having a walker or a cane, whatever their needs are. And second category, improving range of motion and strength. So AROM is active range of motion, so you being able to bend your wrist with no one helping you. And then passive range of motion would be assistance. So it could be your opposite, your unaffected hand helping to bend your wrist. So if you just bend your wrist, you can only go so far. But if you have your other hand helping you push, you can go a little bit farther. And then body positioning, so that's really huge for ergonomic setup. So if someone works from home, they do a lot of typing, making sure that their shoulders are relaxed, their laptop isn't sitting too high, they're not typing for too long, all those kinds of things play an effect into it. And then compensatory prevention techniques. So I see this every single day I work with patients. So if you have like weakness in whatever body part, could be your finger, your wrist, you can only push your body so far. So sometimes people try to, we call it like, cheating through their exercises. So if you lack range of motion, you won't be able to, some of the exercises, be able to complete them, with no difficulties. So being able to increase the range of motion and strength so that you can get back to what you want to accomplish. So that could be work, meaningful occupations, all that good stuff. And 3, reduce pain. So being able to have less pain and improve strength. So we want to be able to, in occupational therapy, help them address what areas have weakness. So HEP is home exercise program. So just like we outline what areas they have difficulty in, being able to address them. So giving them exercises that target it. Like for example, if you lack flexion in your finger, we will give you exercises to do at home that work on finger flexion. If in terms of someone comes in and we ask them like, what's your pain at rest? And they say, oh, it's a 10 out of 10. I feel like I'm gonna pass out, things like that. We don't want that. That would be an instance where we would refer them back to their primary care doctor because that's kind of out of our control. We want the pain to be manageable or minimal so that we can move forward. But if their pain is too high, we have to work on that and potentially refer them back to their doctor. And then return to meaningful occupations. That I've kind of reiterated that time and time again, but that's the the soul, I guess, of occupational therapy. So everyone's meaningful occupation will differ. This could be work, hobbies, day-to-day life, but in short, it's what brings joy and meaning to you. So personally, like for me, something that brings joy to me is being able to spend time with friends and family. I enjoy volunteering with guide dog puppies. That is definitely the best part of my week. And then seeing patients improve, like from their initial visit to the time that they're discharged. But it's a very meaningful and beneficial route in healthcare, and one that I would highly recommend to anyone interested. I also included where occupational therapists work. So it kind of goes all over the place, but most work in hospital settings, so 27%, and then a lot in long-term care nursing facilities. They call these SNFs, so skilled nursing. Schools, 20%, freelance outpatient clinics, that would be like similar to where I work, what fits in that 11%. Home health or traveling OT, so they come to your house to do therapy. Academia, that is like teaching at an occupational therapy school to the students in addition to working elsewhere, or that could be your sole exposure to OT. Early intervention is working with children, usually I think it's babies to age 2 to 3. And then mental health would usually be in a clinic or inpatient. Community, um, I don't know too much about that, but working in the community, so that could be like at a free clinic, I believe. And then others, that was just a different setting. So this study was with 15,000 occupational therapists, COTAs, which are certified occupational therapy assistants, and others within the OT field. So this doesn't represent the entirety of occupational therapy as a whole, but it gives like a good glimpse into where OTs work. So to give a better diagram, so yeah, a lot in hospital setting, long-term care, and so on. But I will say, in my experience of interning, volunteering, and working in OT, I feel like a lot of OTs are either solely for working in outpatient or solely working for inpatient. Not a ton with home health, but definitely a lot of different avenues to take. So thanks so much for watching. If you have any questions, feel free to email me. I included my Insta, my other thrifting page, and email. Does anyone have any questions? Ooh, that's a good question. Favorite is probably getting to see the occupational therapist make the custom splints, because each therapist treats a little bit differently, and each therapist makes the splints a little bit differently. The primary OT I work with, she's super efficient. Some therapists, like a splint will take 45 minutes and she can get it done in like perfect condition in an hour, or a little bit less, maybe like 30 minutes to 45 minutes. Least favorite, that's a tough one. On a daily basis, I would probably say difficult patients. I'm kind of like a stickler for being on time. So we'll have patients who their appointment's blocked out for 30 minutes and they'll arrive like 20 minutes late, like demand to be seen. But there's always something in a career that is going to be kind of difficult. It's definitely helps you to work on your um, patient care skills and trying to be patient and work between your patient care teams. So like with the front office, with the therapist, and but I mean that doesn't happen often. So definitely more good than bad. Um, so prerequisites in undergrad. Did you mean for like graduate school or um, currently like where I work? For graduate school, it differs from one program to another. There's some master's programs, some doctorate programs. I would say off the top of my head for OT school, it's you have to take statistics, bio or chem, anatomy, physio, sociology or human development, medical terminology, and some require an occupations class. So that could be like ceramics or archery or something that is more like a specialized skill. But if you mean like specifically for the work I do now, the clinic I work at is really cool. It's not specifically a teaching facility, but we definitely do on-site training, which is the highlight of, the main reason that I applied there. I actually used to get physical therapy at the same clinic I work at now, so it's kind of nice to be on the other side of the table. But I did not have to take any, like I didn't have to have a bachelor's to work there, but we did on-site training, so I learned basically from the ground up. I didn't know much about therapy before I started, but as of yesterday, it's been 3 years, 2 years as a PT aide and 1 year as an OT aide. So definitely having both sides, both PT and OT, I feel like has definitely made me more knowledgeable in the therapy field. And similarities between OT and PT. Yes, definitely. I would say I get this question all the time, but I always somewhat struggle to answer it. There are a ton of similarities between OT and PT, but like in specific where I work, PT takes everything except for hand injuries. So they'll treat like a hip replacement, knee replacement, rotator cuff, um, lower back pain, neck pain. But if they get like a finger fracture or someone sprains their wrist, like immediately to OT. PTs can still treat it if they feel comfortable with it, but 9 times out of 10, they'll come to OT. And I still work as a PT aide a couple times a week, which is really nice because I still get to practice my skills in that respect. A lot of it carries over from exercise-wise, so that definitely helps out a lot. Okay, so my journey was kind of backwards. So when I was in high school, I had no idea what I wanted to do career-wise. So I asked my counselor at my high school, like, what do you think would be good for me? She's like, why don't you try PT? I was like, okay, well, I just got done as a patient in PT. Yeah, I'll try that out. I got recruited to run cross country and track for the programs I was applying to in high school. And so I went to Cal State Long Beach specifically for running. Academics was kind of on the back burner. And I started taking my physical therapy classes and I hated it. Like every class I took, I was like worse than the last. So I was like, okay, maybe this isn't the route for me. So I ended up changing my major a couple times. I minored in linguistics, information systems, didn't like either of those either. So one of my roommates was majoring in human development and she suggested I try that. And I just loved it. And while I was switching my major to human development, I found out about a gerontology program. So at Cal State Long Beach, they have a gerontology program that's only available as a minor or a certificate for undergrads. And then they also had a graduate program. So I was taking classes for my certificate with just me and graduate students. So I really liked having the exposure to like what graduate material would be like. And also I loved learning about aging. So from there, my mom was a teacher and she used to teach a retirement home. And there was different classes that they would have, and an OT was subbing in for one day. So I shadowed her, and I just loved how she was able to treat so much about the person in such a short amount of time. So from there, I got more experience. I was interning at a hospital, rounding on different floors, and one of the floors was a rehab floor that had PT and OT. And from there, I just was hooked. It was super cool to see the difference between inpatient and outpatient. I initially thought I would hate working with kids, but I interned at an outpatient pediatric clinic, and I really liked that too. And when I graduated, I moved back home, and it just worked out that I lived like 5 minutes away from an outpatient ortho clinic. So that's where I am now. um, Difference between COTAs and OTAs. So COTAs, you have to go to graduate school. It's almost like a technical program. It's usually about 2 years, I think, or a year and a half to 2 years. So you get a lot of more clinical skills. So mainly targeted towards working in like inpatient in a hospital, or you can work in um, outpatient with OTs. Like the clinic I was interning at for outpatient pediatrics, there was a couple COTA students. In terms of pay, it's not great. For OT aides, it's even less, but the experience that you get between OT aides is kind of setting you up, and COTAs too, is setting up really well for applying for OT school to get a graduate degree. COTAs, it's some people use it as like their primary career, but for me, I knew I wanted to do something more so I could be licensed as an occupational therapist and not stay as a aide or assistant forever. And ooh, okay, so my favorite part at Long Beach or CSULB was definitely being involved in the gerontology program. I think that kind of set my experience apart. Like after my first year, I was really distraught. I was having like a really hard time with school. Didn't feel like I really fit in with my team and everything like that. But that was really tough. But definitely, yeah, definitely gerontology is my favorite. And least favorite, probably solely going there just for running. I had a good experience. I just kind of didn't live up to my expectations that I did from high school. But that wasn't necessarily the school's fault. It was just bad timing, wrong place, wrong time. But the school part was great. The running part was not my favorite. I think that's it for questions. There's one I'll answer directly, but thanks so much, guys, for having me. Hope you have a good night.
Thank you so much again for presenting. I learned so much about OT that I like didn't even know. I looked at the presentation and then I heard you speak, and there was so much I learned, and I'm sure everyone else on Zoom and YouTube Live and stuff
Yay.
learned. So thank you again so much. For those in YouTube Live, I'm gonna end the call, but and not end the call, but end the live. But if you are on Zoom, please feel free to